Log on, tune in, find out. Another good idea from Cambridge.
Just about breaking our window back there. Oh, he left.
He will.
Please, Jeremy.
Okay. Thank you for inviting me, Peter, and thank you for not inviting a discussant to show me out.
Quick announcement.
So this is work with my graduate student Laura, and this is definitely work in progress, and it's got quite a bit of relationship to the last talk in some way, which I think you'll find interesting. And I've got the word design in the title, but that'll come along later. And I'm talking about phase 1 trials in oncology again, and thinking about changing the dose as you go through for a patient. And so you can't read all this, but I'll give a little bit of an introduction, something about the model and the estimation methods, some numerical results, and that where the design issues will come in, and then some sort of discussion. So many cancer therapies are given cyclically. So you get a whole regimen, which might be 6 cycles, let's say, and a cycle might last 21 days. And I'll show you some data in a second. And generally the goal, as you've heard many times, is to find the maximum tolerated dose. And that's the dose that will be used in future studies. And generally, you expect to see some toxicities in a study. You're going to see a few toxicities. You don't want to see too many. And you're willing in the future to recommend a dose which has some smallish probability of toxicity. So here's data. So this is not from a phase 1 study, and this is not data I'm going to be analyzing. I'm just showing you to sort of illustrate some of the points. And this is the light just at the top here.
Little red guy.
Little red guy.
Or used to stick down there.
The stick. So this is leukopenia. So this is white blood cell count on a log scale here, and this is a phase 2 randomized trial in sarcoma, 2 doses of ifosfamide and some other treatment too, and a reconstruction of the immune system halfway through. So there's a 21-day cycle, and you can see there's clearly cyclic data here. And so the high dose, these white blood counts, these are sort of population means, go down and recover and go down and recover, go down and recover, and the lower dose, they also have a cyclic pattern. So that's sort of one potential side effect, and the way the protocol is written is this thing, white blood count for a patient goes below some level, you call that a toxicity. So that would be one example of a toxicity in this trial. And another example would be anemia measured by hemoglobin. So here's another pattern. Again, you can see somewhat of a cyclic effect, 21-day cycle, the 2 doses again, but clearly much more of a cumulative effect here. And again, if hemoglobin goes below some level for a patient, you define that as a toxicity, and in the end of a trial, or any of those would count as a toxicity. And here's another example of thrombocytopenia, platelet count. Again, more of a cyclic effect, but a cumulative effect too for a higher dose. So this is the type of data that you collect, and the last speaker was talking about to some degree. But what clinically they do is they just look at the lowest value. If it's below a certain threshold for any of these things and some other things, they call it a toxicity. And what you can tell is that it's in this particular drug, in this particular trial, it's a cyclic effect. So you could potentially get a toxicity for any one of the cycles. So I'm going to be sort of thinking about measuring things for each cycle. But the usual practice in phase 1 trials is not to change the dose for all these cycles, to keep the same dose for every cycle, and to just consider a binary endpoint. And sometimes that binary what did I do here? So sometimes that binary endpoint will be just anywhere, let's say we have 6 cycles. If you see any toxicity in the 6 cycles, we'll call it a toxicity. Quite often in practice, you just look at the first cycle and say, if we see some toxicity in the first cycle, we count that as a toxicity, and that's sort of what goes into the calculation of in these algorithms that are used to escalate. I guess the thinking from just looking at the first cycle is, if you're going to get a toxicity, you'll get it on the first cycle. If you can get through at this dose, you'll be okay. That's sort of one of the thinking, and so sort of ignoring sort of cumulative effects in some sense. But also there's a logistical thought there. You can get the trial done quicker if you can just look at the first cycle. If you don't have to wait too long for every patient, you can get the trial done quicker. So, but this creates a sort of a fundamental problem of what to do if you're looking at a first cycle. So what if a patient actually gets a toxicity on the third cycle? You know, it doesn't like count, but it does count from a patient's perspective. From a drug's perspective, it's not good. So a different approach, is what I'm going to talk about, is thinking about changing the dose from one cycle to the next for the same patient. So intra-patient dose escalation, gather toxicity data, gather binary responses from every cycle. And there was a recent paper I'm going to talk about in a second by Pat LaRusso, sort of talked about this or recommended this in some sense. And this is only going to work if you can sort of assign the toxicity to the cycle. If you've got massively delayed toxicities, this isn't going to work. So you've got to think about something that you can assign to what was given in that cycle. And the accelerated titration design, which is a thing which is out there, it gets used a little bit, it has some aspect of intra-patient escalation. So why won't you do this? You're going to be getting 6 outcome measures per patient instead of 1. So there's extra information in principle. Maybe you can get more precise estimation out of this. So just like the last speaker was trying to sort of get more out of the data, this is a way to think about getting more out of the data. And you might be able to do a better selection of a dose for the next cycle for each patient. So if that patient, you know, if it looks like a higher dose is perfectly safe, and you're on the 4th cycle of this patient, maybe the 5th cycle you can give them a higher dose. So you're giving them a better shot at a good treatment. Maybe you can, at the end of a day after you finished your trial, you have a better proposal of what to recommend in the future. And of course, we're collecting extra data. It's more complex data. We're going to need bigger models, and it's going to have more parameters. So you pay a price in terms of making bigger, more complicated models and more parameters to estimate. So this was Pat LaRusso, someone in Detroit. And I'll give you this reference at the end. So about a year ago, there was I think it was from NCI or NIH, a recommendation, or a steering committee gave recommendations about the design of phase 1 trials. And Pat LaRusso wrote a commentary, and so these are quotes from her commentary. So when designing a phase 2 trial, intra-patient dose escalation is reasonable and should be encouraged, and her thinking was to sort of make sure patients sort of have the opportunity to get at least some higher dose for some of their cycles. That was sort of her thinking. Make it a little more ethical, particularly for patients who are early on in a study. So the second one she wrote was sort of, you got to write into a protocol what you're going to do. And the third one, which I'll copy on the next slide, said data from patients undergoing intra-patient escalation should never be used to guide decisions about further dose level escalation or recommendation of phase 2 doses. So she's saying, well, you do this trial, you're not going to somehow use this data. So I just repeated it there. So what did she mean by that comment? I think she means the data's complicated to sort of untangle, so don't use it. So my thought is, well, the data is complicated, but let's figure out if we can untangle it and then use it. So that's what I'm going to be talking about. So just general goals, you've heard this many times. You find the MTD, however that's defined. You also generally want to be treating as many patients as you can as a higher dose to give them a sort of a shot at the dose doing some good at killing the cancer. You don't want to run a trial where you have exposed or you observe lots of toxicities. You sort of get in trouble. You're not going to be allowed to do that. So you've got to learn something without getting too many toxicities, except you have to have some, but you can't have too many. You want to typically gain experience in the dose you're going to recommend in the future. And that's going to be a big issue of what I talk about. And you want to maybe learn something about the general dose-response relationship. So talk about the models and the methods now. So some notation. So I'm going to fix the setting of 6 cycles as a planned regimen. So the regimen is sort of a plan of what you're going to give in the 6 cycles. And I'm going to consider each cycle you can have 1 of 5 doses, S1 to S5. And YI is 1 or 0. Person I, cycle K, if you get a toxicity or don't get a toxicity. And if you observe a toxicity in a patient, they're usually pulled out of a protocol, you do something different. They don't collect data after the first time Y equals 1. So the ideal would be Y equals 0 6 times. And the data you get will be either all Y equals 0 6 times or maybe 0 0 0 1, and then no more after that. So this is, we've got collecting data on the same person many times, so it's going to be correlated in some way. So any models, the requirements for a model are going to have to incorporate that or allow for that in some way. From the graphs I showed before, you can see there's clearly potential for cumulative effects of doses. Again, that's just for notation. PIK is probability of YIK equals 1. So here, there's a little bit of literature on this, and maybe there's more, but so Rich Simon, sort of who recommended this accelerated titration design, talked about this a little bit and had a model for sort of how you might think about this, modeling this data, and then Anna Legatska and Joe Ibrahim also had a model. And this, I don't think this is exactly either of their models, but this is the flavor of their models. So the probability of toxicity, patient I, cycle K, depends on the cumulative dose term, a dose that you're actually giving at that cycle, and some random effect to sort of induce correlation, or to sort of think about each person has their own level of frailty. So D is the cumulative effect. Capital D, the cumulative effective dose. There's four population parameters here. So we didn't use this. We tried a little bit with this. We didn't actually like it. We didn't think it was very flexible enough to deal with some of the sort of things we're seeing. And actually, Ibrahim and Legatska, when they tried to use this, they actually had to simplify it because numerically it wasn't converging properly. I'm having a lot of numerical trouble. Okay, so that's what we didn't do. So here's what we did do. So it probably looks a little ugly. So think about probability of toxicity. So here's the model. 1 minus probability, log of 1 minus probability of toxicity is linear in these two terms. So here's a cumulative term for current dose and the cumulative previous dose. So this is all about cumulative. And this term here, as this plus sign, has to be positive, is about sort of the effect of a current dose you're giving. And we'll go through this from sort of special cases, so maybe you'll believe it's not ridiculous eventually. And there's a term in here, rho, to sort of deal with correlation between one cycle to the next. Okay, and that term here with that funny symbol up there is sort of a maximum previous dose that patient has received. Okay, so we'll keep going on this. So here's the model written in a different way, just getting rid of a log. Probability of toxicity is 1 minus e to the something. So this e to the something is probably no toxicity. And if you look at some special cases, if you give no dose, you get no toxicity. That's sort of a feature of this model, so that struck me as good. So that was sort of important to, so that's why you kind of have delayed effects. You have to have you don't give any dose, you can't have a toxicity due to something you got in the past. And if another little sort of mathematical feature, I guess, if you give some dose 5 on the first cycle, and you think about probability toxicity from that has to be less than if you gave something first and then dose 5 in the second cycle. So that's sort of a sensible constraint. And some more special cases here. So if you think about just the first cycle, k equals 1. Thinking about k equals 1, capital D and this D dagger, what would that be? D dagger would be 0. And the probability of toxicity would, no toxicity would be just e to the minus alpha d. So this is actually coming out of sort of cell survival models from radiation oncology, and the dose of radiation kills cells, and so there's sort of a motivation for this. If rho equals 0, and beta equals 0, so beta equals 0, no cumulative effect. Rho equals 0 is sort of making things independent from one cycle to the next. And the probability of toxicity is just e to the minus alpha d on every cycle. So this is like independent hits every cycle. So it has that feature. So the idea here is maybe these parameters with reasonable values can accommodate different sort of situations. That's what I'm trying to demonstrate here. If rho equals 1, no cumulative effect, then, and you don't change the dose, then you get no toxicity after the first cycle. So the person gets potentially toxicity at the first cycle. If they can make it through the first cycle with that dose, they're never going to see toxicity again. So they have a frailty level, and you've sort of calibrated it on the first cycle, and then once you pass that, you're never going to see toxicity again. So those are, maybe there's more. Okay, so the alpha term is sort of the controls the non-cumulative effect. The beta term controls the cumulative effect, and the rho deals with sort of correlation and frailty. So, so that's the model we arrived at. And to sort of demonstrate that it's got some flexibility to cover different type of situations, so we're just going to look at 4 different scenarios, 4 different sets of these values for these 3 parameters. And I'm going to show you some pictures in a minute. And these pictures for schedule, there'll be 5 possible schedules. It's either everyone gets dose 1, S1, all 6 times. Everyone gets dose 2, all 6 times. So just no change in dose for what I'm going to show you.
Is it possible to ask some clarification question?
I think so, yes.
Okay, thank you. In your model, you introduce probability for one individual, so it's P sub I K, so it's probability for one individual. Let's assume that I'm that individual and I have, say, at the second set of toxicity. So I know it's no probability at all. So then, probably I will have toxicity on the next second.
I stop collecting data. If you have toxicity, you get off the protocol.
So that's what I'm trying to understand. But in model itself, it is not reflected.
Right. I'm not.
Like
I don't.
That model. So
I don't need to model. I don't need to make assumptions about that because I'm never going to be collecting data about probability of toxicity later if I've already got toxicity now. So it's part of a distribution structure I don't need to even think about in some sense.
yeah, but somehow it should be implicitly included in model. So if it's 1, I observe 1, then that's all.
Only if you want to predict the impossible event, right?
I mean, I could make a model for it, but it wouldn't enter into any likelihood. So.
Toxicity is death for him.
Yeah, that's true.
Except for one historical exception, there's no
They're out of the
Yeah, but it's
protocol.
not in the model. So it's some contradictory. Oh, okay,
All right.
I try to understand. So if it's not there, so it's not
All right, so 4 cases, different values of alphas, betas, and rhos. So you probably can't see this very well, but there's 5 lines on each of these little graphs, and each graph corresponds to the 4 scenarios. And what, for example, you see in case 1, various values of the parameters. So the top line is the proportion of toxicities you'll see among a large number of patients at the first cycle, at the second cycle, at the third cycle, etc. So in this case 1, and the top line would be if the plan was to give the highest dose 5 times, 6 times in a row. So, and this is a case where, if you see a toxicity, it's most likely to be at the first cycle. If you can get through the first cycle, you don't see much toxicity later on. So those parameters sort of deal with that scenario. And then you look at the top right, it's a scenario where you can see toxicities later on, and there's clearly a cumulative effect of a dose. So this is supposed, there's various different patterns you can get, maybe not as many patterns as we'd like, but there's quite a bit of flexibility by changing the model parameter values. Okay, so that's the model. So the estimation challenge is to be, take that data you've got and use it in some way. I guess that's why it's adaptive. And it could be during the trial to think about the dose for the next patient, or it could be end of a trial once you've collected all the data and you want to sort of make some story at the end of the day. And we're using WinBugs. So the likelihood, because of the nature of a model, Markov, it's just a product of product over subjects times a product over the cycles they've received data. Simple sort of likelihood and various priors, which we could go into, but I'm not going to today. So I'm going to show you some numerical results of playing with this model. And so I'm thinking about a single trial of 30 subjects. So this is really I'm trying to answer the question now is, if I had some data at the end of a trial, can I analyze it? Can I expect to sort of get realistic estimates of the model parameters and the probabilities implied by those parameters? So let's look. So at the end of a trial, I've just assumed that we got to a situation where 3 subjects, their schedule was to receive dose 1 6 times in a row, and 10 subjects, their schedule was to receive dose 4 6 times in a row. So that's sort of, on the end of a trial, and this was just the data I might get at the end of a trial. And so, we did that, simulated data under that scenario, 50 different trials, and looked at, estimates of the parameters, and there's 4 cases again, and I guess so alpha is, the true value is 1, and you get estimates sort of near 1. When the true value is less than 1, you start getting estimates a little less than 1, but it's not as low as 0.3. So, you're not going to get great estimates from 30 patients of parameters. But it's sort of doing the right thing, and there's priors in here which help play a role too. Getting Winbugs to do this to our satisfaction took quite a bit of time. And then, from that same scenario, why bother to do this? If you don't get any more information than just collecting a binary response from every patient, it's not worth doing this. So this is saying, do we actually learn more than what you would learn if you analyze this data in a different way? And this data was set up so the dose never changed for a person, so I can just consider a binary endpoint for the person across the whole set of doses. And V equals 1 represents that binary endpoint. So toxicity any cycle, and I can fit some sort of standard type 1 parameter, or it could be 2 parameter, but anyway, 1 parameter CRM model, and we do this with a Bayesian prior on the parameter W. Okay, so then I've got 2 ways of analyzing this data, and when I'm going to show you some results in terms of what I want to get out at the end is how well do I estimate not the parameters, but the actual probability for the person. And so I can calculate that probability for the person either from the truth, because I know how I simulated the data, from the estimates, from the method that takes account of all the cycles, or from this method which just uses a single binary endpoint. And so each row is a probability of toxicity anywhere for each of the 5 possible schedules, and the truth 0.026, the CRM or 1 parameter model give you 0.27, 0.28 here. So the bottom line is that it doesn't do ridiculously badly in terms of bias. It's sort of, we're satisfied with that. But you start to see some gains when you think about uncertainty of efficiency. So that's what you'd expect here. Or you'd hope for more data. Maybe you'd get more efficiency despite having more parameters to estimate. And so you can look at the mean square error of a point estimates across the simulations, and it tends to be smaller for the Markov model than the single variable model. And it doesn't, not always the case, but usually the case. If you think a posterior standard deviation of those probabilities tend to be smaller from the Markov model than the CRM model. So there's some potential for gaining efficiency here. So this is sort of saying it's worth going forward with this idea. Okay, so now getting a little more into the design stuff, and this is where we welcome your ideas. So this is, imagine you're in the middle of a trial, and we've got 4 patients have already seen some data. So the first patient, so the notation here is first patient S2, they got dose 2, cycle 1, and did not get a toxicity. When dose 2, cycle 2, dose 2, dose 2, dose 2, and then dose 3 on cycle 6, didn't see a toxicity. The second patient got dose 2, dose 2, dose 2, and what do we give for cycle 5 for that patient? That's the thing we want to do, and we don't have to give dose 2, we could give something else. Subject 3 got dose 3 at the first cycle and got a toxicity. Subject 4 got dose 3, what do we give for cycle 3 for that patient? And then a new patient comes in, what do we give for that patient? So that's the challenge, that's sort of the design challenge. And just, any practical trial, you have to have some restrictions to make people feel comfortable. You can't just totally rely on the models to tell you what dose to give, because if it goes wrong, and you do things like skipping doses. You've never tried dose 3, and all of a sudden the model says try dose 4. That's not going to be just acceptable. I mean, they won't let you skip. Well, my experience is the clinical people will not let you skip doses and do things which are sort of out of line with their sense. So we put in some somewhat mild restrictions, and we start at S2, which I recommend generally. And we also had a rule that you had to have some experience at a certain dose before you escalated to the next dose. So all these are arbitrary, but so we need to just have four patients or 4 cycles that had to be experienced at some dose before you could skip.
But this is within a subject or?
No,
in
this is
general?
across all subjects.
Okay.
So yeah, those 4 cycles could be 2 from one person, 1 from another, 1 from another. So here's how we made the rules, our ad hoc rules, for what dose to give the next patient. And there's some various probabilities you can calculate here. So there's A, B, and C are 3 sort of probabilities you can calculate. So and how do you do those? How do you calculate those probabilities? Well, you've got some data, you do your Bayes thing, you get the posterior mean, and then from that posterior mean, you can calculate, predict estimated probability of toxicity on the next cycle for that patient, given their history and all the data you've got on the other patients. And so A here is just the probability of a toxicity on the next cycle if you give dose D. So it's actually just Pij. So this is just a complicated way of writing Pij. Probably, so just for next cycle for that patient. And that might be the second cycle. It might be the 5th cycle. So the second one, B, is thinking about sort of a future that patient. So there's a calculation of what the probability of toxicity for that patient in the future would be if your plan is to give dose D, 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 D every time, not to change a dose. And so let me just talk about, so the rules we had, what I'm going to show you is A, probability of toxicity in the next cycle had to be less than 15%. B had to be less than 40%. So the idea, B being a bit bigger, was, well, we're saying in the future you can give dose D, 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 but you're willing to be more aggressive because maybe you can back off. You've got the option of backing off later maybe, so you can be more aggressive there. And then C is a calculation of a probability for a future patient of toxicity if they were to have got what the current patient in front of you had up till now and got dose D everywhere in the future. And so you can calculate that too. So that thinking there is just like the CRM and those model-based type things. You tend to want to give doses which have an expected probability of toxicity equal to some target level. So in here we're going to specify 30% is sort of where we want to be collecting data around schedules of doses which give about 30% toxicity. So this last line, this calculation C, is just a probability of toxicity designed to give about 30%. And so the idea is to sort of force ourselves to some degree to collect data around expected probability of toxicity around the target level. Okay, so here's what actually happened. This is just a single trial, just a numerical exercise in simulating data from this trial. And so this represents, there were 30 patients, cycle 1, 4 toxicities happened. So only 26 patients got to cycle 2, 3 toxicities. 23 patients, cycle 3, 0 toxicities. So you can see total among these 30 patients, we observed 8 patients got toxicities and 146 cycles were given. And if you look at the pattern here, most of the patients for cycle 1 got dose level 3, most of them on cycle 2 got dose level 4, most on cycle 3 got dose level 5, and then it tended to stay around 5. So that was sort of the implications of those design rules were to give this pattern, generally. And I'll show more pictures of that later if I don't run out of time. So so we had one data set, and at the end of a study, we can estimate the parameters, and so these are the posterior means for the alphas, the 3 parameters. And so what would you recommend at the end of a study? I've collected this data where people bounce around in the doses they've got, and I'm probably not going to want to recommend of a doctor, your optimal schedule is dose 1, dose 5, dose 3, dose 2, dose 4. It can't be too wild. That's sort of just not going to go down well. So we restrict. So you may want to limit the number of changes in dose. So we restricted ourselves to 1 change in dose as a possible recommendation. And so here are different possible recommended schedules. So here, you know, S1, S1. So you just stick with dose 1 all the way, or down the bottom of a table, the first 3 cycles are dose 4, and the next 3 cycles are dose 5. So we allowed ourselves 1 change. So at the end of the day, this is sort of all the things we might be willing to recommend, one of these. And just from the estimated probability of toxicity, we want to be something around 30%, a little less than 0.292 is the estimate of this one, S4, 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 S5, S5, S5. So that could be a recommendation at the end, but who knows if that's so this is, you know, this is all, no optimal design here. This is just, you know, what we think is sort of acceptable and realistic and plausible. So this just says possible conclusion at the end of a study. All right, so look, a number of sort of talking points, if you like, or conclusions. So as I described those these criteria for choosing the next dose, those calculations of probabilities, ABC, you could modify that a little bit and think about different levels of toxicity which might be acceptable on the different cycles. So cycle 1 has an acceptable target level of P1 star, and cycle 2 has a target level of P2 star. So you might be, those may not be the same. You might be more willing or less willing to accept toxicities earlier than later. So you can choose these P1 stars up to P6 stars to give you an overall target toxicity level for the whole trial. And then each cycle, you just choose a dose to hit the one relevant to that cycle. Or another criteria you might think about, and we haven't really got too far on this, but we'd be interested in people's ideas, define something you're trying to maximize, you're trying to optimize on. So this is, you know, generally you want to give as high a dose you can. So the higher dose before you get a toxicity is what's desirable to make that big. So if you can set that out as a criteria and have that drive your decision about you know, what dose to give, and I don't know how to do that. So I'm going to actually just show you just a little case study of a scenario. The thing I showed before, the A criteria was set, it has to be less than 15% for the next cycle. So that's for P stars, have to be 15%. I'm going to show you a scenario B where you allow 25% at the first cycle, but you allow lower percent at the next cycles. So that gives you the same overall percent toxicity rate if you were to hit these P stars. And you get pictures which look colorful somewhat, probably not to you. So these are just patient profiles of what happened in the trial. So I sort of showed this more or less before. So these are the first 2 patients, started at a low dose, and we didn't sort of allow things to start too high a dose, but then they escalated up, and you know, the 3rd and the 4th patient started here, and you know, as we learn, we think we can escalate safely according to the criteria, and so you see most of the patients start at dose 4, and the pattern is dose 4, 4, 4, 4. No, dose 4, then 5, 5, 5, 5, and then some come down, some don't. But there's also patients who go up, come down, go up, come down. So that's just one realization of a simulation.
You can make doses less than on the previous. So it could be also.
Yeah, how would that happen? Because you would only reduce the dose if you believe it's too toxic. But by definition, you don't observe y(i)k = 1. If you do, then you stop.
So I still have that data for y. So I've learned in the meantime, a couple of toxicities show up between the time I gave a previous cycle to the time I'm giving the next cycle. My estimated parameters would change, and we may say go down in dose.
The data can only come from other patients.
Yeah, it can only come from other patients, right? So it informs these population parameters. So this is scenario B, just one realization. So in this case, we were allowing more toxicity in the first cycle and less on later cycles, and so there was a few patients who started on cycle 5. But generally on the later cycles, we allowed less toxicity. So sort of the implication was, or the expectation was, that it would be some sort of reduction in the dose in later cycles, and so you saw that mainly along at dose 4.
And what was the rule for dose de-escalation?
There was no, it could jump down from 5 to 1 if the model said it could. If you'd gathered data from other patients, which informed the parameters, such that the choice for this next patient was so bad at high doses it could jump all the way down.
It can only go up one at a time.
It can only go up one at a time, but it can jump down. It doesn't, it's unlikely to actually, but it could.
At CRM, he wants to get closest to 30%.
Then back.
So just another sort of thought here. So sort of trying to utilize the type of work that Susan Murphy and people who are thinking about dynamic treatment allocation are using now. So think of it as a dynamic programming problem. So I want to, so you start at the end of you start cycle 6. What is the optimal at cycle 6? And if I could define what optimal means, I could have, I could have a strategy for cycle 6, whatever situation I came in, and then step back and say, at cycle 5, now I've got to make the decision about what to do at cycle 5. I want to do something optimal, given that I know I'm going to do something optimal at cycle 6. And so you can sort of step back in that way. So you sort of think more, not just about a myopic next cycle, but you think about the whole schedule in that way.
But you have to include all other patients too. That's what complicates it. Right?
Yeah, we haven't got any further than this slide, actually. There's the idea. So, interested in anyone knows any work on that? So just a few other discussions, sort of a modeling the estimation issues here. So I think we were quite pleased with ourselves for the model we came up with.
Why at Stanford says there's been a big breakthrough in the computer science community on the essential bandit problems for more than 3 doses. I can't tell you any more than that.
I mean, yeah, so you get into massive computational problems here because you have to sort of start enumerating every possible path through the future, and it's just monumental.
He claims that that is now
Good.
Yeah, that problem of allocating, optimizing each cycle under the assumption that each for subsequent cycle will also be optimized. That was what I did in my presentation on Tuesday, and it took the computer for a trial with only 5 patients. It took the computer a whole night to optimize it, and it led to practically identical design to what Luke showed with the penalized D-optimal design. You cannot really distinguish the 2 designs from each other. So, and that is an algorithm that would just run and optimize, that would achieve the same design in a fraction of a second. So maybe, of course, your scenario is different, but it's quite, yeah, maybe worth a go to see if optimal, penalized D-optimal design would give something that is very close to being globally optimal.
That would be good.
Should we let him finish the talk and start it off?
No, that's good. I mean, I'm looking for.
Finish your talk.
I haven't got too many left. So, the model parameters. As I said, we're quite pleased with the model. I think it's a challenge because you've got too many parameters for not enough data, particularly early in these trials. So the priors play a sort of important role in stabilizing the estimation. I don't know, as Peter Fall was sort of using them yesterday, they're tuning parameters in some way. But I mean, but also there tends to be a little bit of prior knowledge, so you can use justify from a sort of classical sense using mildly informative priors here, I think, as well. So going back to these general goals, so finding the MTD, but now it may not be unique in some sense. MTD is a sequence of doses. So what does it mean to find the MTD here? And you definitely want to, one of the general goals is to treat patients at doses which might be efficacious. So allowing escalation of dose is clearly a way to achieve that to some degree. So another point, you want to gain experience, as I said earlier, you want to gain experience at a specific dose that will be recommended in the future. So that's sort of a real issue here. I'm bouncing around doses to try to learn something. It's hard at the end of the day to end up with a sort of likely to hit the schedule. Actually, in 0 patients in the trial are quite likely to have a schedule I'm going to recommend. So, the way they do that now is just to define an expansion cohort. You sort of tag on 10 more patients at the end of the day and you run them on the schedule you recommend. maybe you probably do learn something about the dose response here. So clinicians, so from a clinical perspective, it's probably a little more ethical to do this than just sort of keep the dose constant. But talking to clinicians, you get different ideas. Some of them want to, depending on the context and the drug and the scenario, their sort of idea is hit the dose hard, early, kill it, stop it growing, whatever it is, block the angiogenesis, whatever it is. So that sort of calls for, high dose early, but then maybe you have to back off. So there's a modeling that will allow you to back off later. But from another perspective, they don't necessarily care too much. A toxicity on cycle 1 is quite different than a toxicity on cycle 6, because they've already got the dose. If they've got to cycle 6, and these toxicities tend to be many of them, not all of them, many of them tend to be reversible over time. You can give, things to reconstruct the immune system, and so it's not, so this is sort of a reality, and so this sort of argues for, maybe discounting toxicities that occur late in some way in your sort of optimizing function. Will it be accepted? Who knows? We're not actually doing this yet. So this is sort of the stage of seeing, is this potentially worth pursuing? Is there going to be sort of gains in efficiency sufficient to complicate things? And I don't know about most of you, but anything complicated is, I don't want to touch that. It wants to be simple, it has to be simple. So this is clearly not necessarily simple, but it might, if it's worth it, then it's worth pushing. It doesn't involve a collection of any additional data. This stuff is being collected anyway. It doesn't delay the conduct of a study in any way. And so just sort of backing off a little bit to the big picture, and Kunman Kim yesterday, he's not here today, but he talked a lot about sort of, what's going on in oncology trials, and it's not totally clear, but what I'm doing or what I've heard of a lot of talks this week are quite sort of in the same line as where the clinicians are thinking and where the biologists are thinking in terms of targeted therapies, and they were trying to measure efficacy and toxicity at the same time, and it's not total. So the models I've got are based on sort of implication that bigger dose gives more toxicity, and for targeted agents that's maybe not quite so clear, and a lot of the trials will be, I believe, a standard agent which already has a toxicity profile, and you're adding a new agent. That's sort of the thing that people are looking at. So I don't know, in my mind, there's a lot of interest in sort of combining the phase 1 and phase 2 type trials to learn something about the efficacy as you collect on the toxicity as well. And Peter stood up, so it's probably time to stop. So these are just for references for the 3 papers I mentioned. Thank you.
Peter and then Stephen.
A couple of comments. I think Yuan Ji may have mentioned to you we're working on the same problem, although we're approaching it quite differently. But two comments. One of them is that a very large proportion of the phase 1 protocols that I see have algorithms, deterministic algorithms for within patient dose escalation over multiple cycles. So they do it all the time. But
they're usually for de-escalation. If you see something, de-escalate. I see that a lot. I don't see too much escalation.
The escalate as well. But the other point is one of the main issues in dynamic treatment regimes, namely that if you think for simplicity of 2 cycles, if someone optimizes only for the first cycle versus optimizing over 2 cycles in order to get some kind of payoff, it's very easy to construct examples where the optimal 2-cycle strategy does not have as its first treatment the optimal myopic treatment.
Right.
And the standard example of that was given to me by Randy Milliken and Andy Anderson is that if you come in fast and strong, as in that example of yours, with very, very aggressive therapy that's very immunosuppressive, and you fail to get the tumor into remission, then the patient's immune system is so beaten up that whatever you give them in a subsequent cycle is very unlikely to bring their cancer into remission. And so it's very easy to show that that's a very bad way to go about cancer therapy.
It's interesting because it's the bone marrow transplant docs at my place.
Bone marrow transplant.
I'm not talking about transplant, that's a
No, but
different
that's
group.
the idea.
In
But that's-
transplantation, they plate.
Right, so it depends on the context.
Oh, yes.
That exactly depends on the context. The bone marrow transplantation folks like the idea of hit hard.
Transplant, in stem cell transplant, where they have ablative regimens, there the winner loses within a 100-day window. So So they want them alive and engrafted without a disease recurrence at day 100. It's a different ballgame.
Stephen?
I have a question and a comment. The question is that, could you imagine hypothetically that the set of parameters you get from a trial you've just designed could be used for the same drug for another trial just coming up? Would you reuse the alpha and beta and
I think
rho, etc.?
Yeah, I think I would use the information I've learned, whether I'd formalize it as the alpha beta rho, I'm not, but I would try to use it, I think.
I'm just saying that what can you learn from this trial about subsequent trials? Because the corollary question, of course, is that you've actually got a lot more data than what you're using, because the ones and zeros aren't true. It's not like that the person's alive or dead. The ones and zeros are, is my white cell count less than 1? So if your white cell count's 1.1, as a note, if you measure it again, it might be 0.9 next time you measure it. So in actual fact that you're just getting an instance of a potential toxicity, rather than the probability of the toxicity condition on some blood level being this. So in fact, if you considered your a nadir white cell count to be a continuous variable and ask what's the probability that this corresponds to toxicity, and then model that, you get a lot more information than just use the ones and zeros.
So
Just to take that one stage, you take Marina's tool, which says, well, let's just treat the white cell count as if it were a continuous variable and actually model the white cell count. And you have a model which allows for feedback of the system and sensitivity on future doses. Then in theory, then you have a model which has lots and lots of data of which you could predict a large number of parameters and use this for predictions into new data sets and new trials.
I mean, I would like to do the sort of modeling, you know, taking into account all the data. I mean, the reality in these trials is they stop giving the drug based on criteria for these things, you know, for the white blood pen and the hemoglobin and something else, and if you die from disease, and if, so it's, the models have to be awfully big to be sort of transportable into the next study.
You have a censoring criteria, not a toxicity criteria. The toxicity criteria is based on somebody believing what they see. Therefore, you're censoring the data at some point. It's not saying the fact that you've actually got toxicity. You've just got a
Okay, what's the okay, it's all in the definition of toxicity, right?
You want to change his data.
Well, it's something that using it as 1 zeros is
Oh, I couldn't agree with that more, but I mean, that's what, the 1 0 is a heterogeneous set of conditions.
Ask solutions to give you more.
Oh, well,
Yeah.
Good.
Be hard about
I
it.
think many of us could agree on that. Valerie?
So, one pre-question. So, did I understood you correctly that you, for each patient, you have his own probability, change with steps, with escalation, but for each, so you have population model for probabilities. Is it correct?
the nature of a Markov model gives me a probability estimate for that patient as we're in the trial.
But this probability is picked up from some population. Is a population model.
And the,
This, you introduce P sub I.
it's a Markov model, so if the probability at time k is a function of the dose they've got before. So it's a population parameter, if you like.
It's population parameter, but to the very large extent, what you are doing, you actually you use actually geometric model. You toss a coin on each individual, and as soon, let's assume the same dose, as soon as you have a head, you stop.
That's the model.
So it's
Yes.
typical geometric distribution.
Although the probabilities change.
But probability change is another thing which I. So it's geometric modeling. Let's assume I consider very simple case that I do not change doses. Okay. So and if I mixed probability in this way, so mix geometric distribution with whatever population is, with gamma or with something, and I have to only one measurement on each individual, then I actually cannot restore or cannot estimate individual parameters.
But the parameters are not
But-
individual, right?
Parameters are individual.
Because
So
of
if
the
I'm
Markov
not
model.
Bayesian, then I cannot estimate them.
There's a likelihood, the parameters are identified through the likelihood. I mean, they are
That's
estimable.
theoretically, for Y, for example, you cannot do this.
The parameters have no I index. The
No, they
probabilities
can.
have.
No,
The
the parameters have no
probabilities, not
I.
the parameters.
The parameters have no I.
Parameters are alpha, beta. They are not depending
Alpha,
on
beta, rho.
population.
It's only
So it's
beta.
not population model.
Yes, it's population.
But
For the probabilities, not for the parameters.
Yeah.
Alpha, beta, rho have no I index.
Okay.
They are.
Something.
It's all in the details of a model, the answer to your question.
Sorry, I didn't mean to. Basha?
I have a question for not just for you, but for people who have some experience in drug development, more hands-on. In such very early trials, is it the case that the patients are chosen in a way that they have similar characteristics? Like we know that for cancer, what is important is size of the tumor, is the lymph nodes affected, is the grade of the cancer, and with the early stages of cancer, you don't have to probably have high doses to help the person. As later stage, you need higher doses. Is this taken into account in any way?
We would like to have covariates in this model to sort of adjust for, but I mean, this is toxicity, so I mean,
These are called entry criteria.
Well, yes, but we
These
don't
are-
need high toxicities for early stage
What
patients.
What you're talking about are called the entry criteria of a
Yes,
protocol.
yes, that's right.
And when you do early phase trials, unfortunately, they tend to be rather broad. In many protocols, I've seen mixed diseases.
but they tend to be advanced patients.
But
They
then
tend
we
to
have
be,
all this variability which could have been explained by taking into account this
Yes.
entry
oh,
criteria.
absolutely.
Absolutely.
trial.
Absolutely.
Bring in covariates would
These
be great.
protocols are insanely heterogeneous, and they're begging for covariate adjustment.
Guys, it's lunchtime. Thanks to all the speakers, bon appetit, and come back at 2 p.m. for our last wonderful session.